All right, so there are some limitations for drug therapy for AFib, but sometimes we can find a good solution that's adequate or excellent. If not, we have procedural options for managing AFib. And this is where we start talking about Afib ablation. There's, again, two ways we can do an Afib ablation. One we call our catheter-alone Afib ablation, and the other one is called our hybrid ablation. So we'll talk about both of these. At the end of the day, no matter which way we do it, you end up with the same general result. There are some differences, and I'll talk about those. So the idea behind this is that when people go into AFib, go back to our pond model again, our best understanding of why people go into AFib is that there's some skipped beats that fire off and throw the rest of the atrium into AFib. So in our pond model, picture it like there's some rascal on the other side of the pond with a handful of stones. And every once in a while, he starts chucking them in your pond real fast. And you have all these competing wavelets and ripples from these skipped beats that essentially can cause the rest of the atrium to degenerate into AFib. Those hot spots of electrical activity are most typically from the region called the pulmonary veins. So the pulmonary veins, there's typically 4 of them, 2 on the left and 2 on the right, and they bring the oxygenated blood back from the lungs to the back wall of the left atrium, where that blood's then going to get pumped through the system and out to your body. These are pretty good sized veins. They're usually about the size of your thumb or your finger, so they're pretty decent size. There are some, it's not quite as stylized as a pipe going into a boiler where these veins merge into the back wall of the heart and there is a demarcated seam of transition. There is more like a conical transition zone where a vein is merging into back wall of the heart. And there can be some sleeves of heart muscle tissue that extend out into these pulmonary veins, sometimes several centimeters. It's this transition zone here in the sleeves of pulmonary vein leading into the left atrium that are typically the hot spots for these skipped beats that throw people into atrial fibrillation. So if you picture our antiarrhythmic drugs thickening up the viscosity of the water in your pond, we're trying to make the pond more resistant to going into AFib when these stones get chucked in. When we do an Afib ablation, basically we're trying to electrically isolate these pulmonary veins from the rest of the atrium. So if there's firing from within these pulmonary veins, you can think of it like putting a containment buoy around these hot spots of skipped beats. So the pebbles drop inside the containment buoy and the ripples don't get out, and the rest of the atrium out here is unperturbed and you don't go into atrial fibrillation. So it's 2 angles on the same theme. Logistically, how we get these containment buoys in there goes back to the idea of doing an ablation. So this is what I call an Afib ablation, as opposed to what we mentioned briefly before, this AV node ablation. What we do is we put a series of catheters through the vein up to the heart, and then we have to get over into the left atrium. That's done with what's called a transeptal catheterization. Basically, we get our catheters over to the left atrium. Then we have a very elaborate computer system that helps us make a 3-dimensional model of what your left atrium looks like. In the preparatory phase to doing this, we typically have folks get a CAT scan. The CAT scan, they put the images on a CD. I bring the CD over to the hospital, put it into our computer system, and can make this 3-dimensional reconstruction of what your left atrium looks like. Most people do have the 4 separate pulmonary veins, but occasionally we find that folks may have one big vein on one side, or they might have 3 veins on the other side. There are unique variations in pulmonary venous anatomy. The CAT scan helps me get a roadmap in terms of what to expect and how to plan my ablation. But when we're in the procedure room, then we can use the CAT scan as a model, and then as we move the catheters around inside the left atrium, we can recreate this 3-dimensional model that looks just like the CAT scan and identify all of the pulmonary veins and where they are. We have a special little circular mapping catheter that has a whole series of little electrodes that look like numbers on a clock. And we can park that into the opening of each of these pulmonary veins And on our elaborate recording system, we can display all the electrical signatures from each of these different electrodes. And we can see that there is electrical activation in these veins. So if you picture this is the back wall of the heart and this is the vein, I take my ablation catheter and basically put it in one spot, deliver the electrical energy. It heats the heart tissue right there and makes a permanent thermal burn about the size of the footprint of a pencil eraser. And then I basically walk this catheter around the outside of the pulmonary vein, sequentially delivering these focal spot welds until I get a complete encircling scar line around the pulmonary vein. So that if there's firing in here, again, it moves through the wall of the heart, basically hits this roadblock and fizzles. And the rest of the atrium out here isn't perturbed by these skipped beats. Now, we have to do that for all 4 pulmonary veins. And we can both make sure that the signals can no longer get into the pulmonary vein by putting that circular catheter inside the vein after we've completed the encircling line. We see that the electrograms are basically all gone. And we can pace from within the vein and show that the signals can't get out. So we get entrance and exit block from each of the 4 pulmonary veins. Typically, if you picture the back wall of the heart, like if you're looking at me, there's 2 veins that come in on the back wall on the right side and 2 veins that come back on the left side. And sometimes we do these in block, so we go actually around both veins in one giant circle. Sometimes that can actually set people up for another rhythm problem called atrial flutter, where if you picture this scar line, this circle, now as the center of a racetrack, and the electrical signals, potentially at least, can loop around the outside of these things in a circle. That might fix atrial fibrillation just fine, but now folks may have these atrial flutters. So in order to prevent these atrial flutters, here's one big circular lesion here and one big circular lesion here, and the flutter can potentially loop around this one or around that one, and sometimes it goes around both in a figure of 8. Basically, I draw a line from this scar line to this scar line and do what I call a left atrial roof line, which prevents flutters from looping around these other circuits. So that's the basic idea behind an Afib ablation. In terms of efficacy, in ideal candidates, Afib ablation will prevent recurrent Afib in about 75 to 80% of folks. So again, it's not perfect, but it's better than all of our anti-arrhythmic drugs in terms of preventing recurrent atrial fibrillation. The benefits of it are that you don't have Afib in the majority of cases. You may not need medicines to control the Afib, in particular the anti-arrhythmic drugs with their potential for pro-arrhythmic side effects. Or for that matter, rate control agents. Since you're not having Afib, you don't need to be on rate controlling drugs to prevent fast rates from Afib. So when it works really well, it works really well, and people are delighted. Basically, forget they even have a rhythm problem because there's just stay in normal rhythm. 75 to 80% of folks, we can achieve that target on the first go round. That implies that 20 to 25% of folks may have recurrent episodes after one of these Afib ablations. Now, what we do at that point for those folks that have recurrent symptoms kind of depends on how much Afib they have. Some folks may have a spit or a flurry of Afib for 5 minutes once a year, and we kind of let that go and just say they're happy enough. We don't really need to do a whole lot more. But if they keep coming back with recurrent bouts of atrial fibrillation, then they're still unhappy. In those cases, sometimes they respond better to antiarrhythmic drugs than they may have before the Afib ablation. We might try that, but more likely what we do is bring those folks back for a redo procedure. And we go back up there with our catheters, and we can look at the integrity of these ablation lines where they encircle the pulmonary veins. More often than not, what we find is one or multiple of these veins have become reconnected. Remember I said I do a series of little punctate spot welds, and when we finish the day of the procedure, this scar line appears intact, and there's no communication across the scar line. But with time, as the swelling and inflammation from those ablation lesions starts to resolve, just like picture you got a burn on your arm from a match or something, It's hot, red, inflamed. Over the course of a couple weeks, it starts to mature into a final form little scar. Same thing happens inside the heart, and there's the potential at least for these little gaps between the lesions. And a thread of heart tissue may still be viable, connecting the vein to the rest of the atrium, and the signals can again get out and throw people into AFib. So we can go back in with our mapping catheter and reassess the integrity of these ablation lines. Sometimes it's only one or two little spots that we have to re-zap, and the whole vein set gets re-isolated. In folks that have redo ablations, usually we can recruit at least half of them into the long-term success camp. So with up to 2 procedures, we get about 85 to 90% of people symptom-free long-term. It's still not 100%, but it's a pretty good chunk of them. And it's much better in terms of long-term efficacy than long-term anti-arrhythmic drug therapy. Now, there are some risks doing an Afib ablation, and those have to be factored in as well. Between 2 and a 4% chance of a complication doing an Afib ablation. Some of those are small, but there are a couple biggies that you have to be aware of. So for example, we don't want to injure any blood vessels when we put the catheters up through the vein. When I'm doing my ablation, I don't want to have any unintended injury to the heart wall. For example, a perforation of the atrial wall when I'm doing one of my ablations. That potentially could cause literally a hole through the wall of the heart. The blood can leak out into the sac that surrounds the heart and compress the heart. That we can monitor for that in real time while we're doing our procedure. We actually have a little ultrasound probe up in the heart that we can in real time see the heart and see if there's any fluid accumulating. If there was a perforation with fluid accumulation, we would have to abort the procedure while we're at and urgently drain that fluid, usually with a needle through the chest wall into the sac that surrounds the heart, and drain that fluid out. It's a fully recoverable complication, although it's a bit harrowing at the time, but we have had that happen a couple times. Each time the patient has done very well. They stayed an extra day in the hospital. They went home. All of them essentially came back a month or two later, and we picked up where we left off and finished the procedure. But it does result in an incomplete procedure that day, and ultimately you may need 2 procedures to effectively get one job done. Other things we don't want include stroke. So we'll talk about anticoagulation in a minute, but basically we have you on usually pill-form blood thinners before and after the procedure, and while we're doing the procedure, we put you on a second intravenous form of a blood thinner to prevent blood clots from forming on these catheters. We don't want any blood clots flicking off, floating through the circulation that could potentially cause a stroke. Risk of stroke is typically less than 1%. Fortunately, we've never had anyone have a stroke from one of these procedures, but I don't want to start. As a precaution, usually the day before we do an Afib ablation, we do something called a Transesophageal Ultrasound, which is where they numb up the back of your throat and they put this flexible scope down your swallowing tube that goes down right behind the heart. And from that vantage point, they can get very high-resolution ultrasound pictures of the heart and actually see if there's any clots in the left atrium or anywhere else. 98% of the time, we don't see any. But we want to make sure there aren't any clots, because the next day I'm going to put catheters up there and start twirling them around inside the left atrium, and I don't want to dislodge any clots that could potentially embolize and cause a stroke. So in the unlikely circumstance we did find a clot on that transesophageal echocardiogram the day before the procedure, it would be a showstopper for that procedure. We would have to make other arrangements. Risk of stroke is low in general. Now, the final thing on the big ticket items of the complication risk is injury to the esophagus. I already mentioned that the swallowing tube or esophagus goes right down behind the heart. So if you picture this is the back wall of the heart, here's the esophagus coming down right behind the heart. And I'm going to be putting ablation lesions in from the inside, pushing backwards against the esophagus. I don't want to have any thermal injury that can actually injure the esophagus here. In some cases, that can cause an ulcer in the esophagus. And in the worst case scenario, there can actually be a welding of the esophagus to the back wall of the heart and a microperforation here between the esophagus and the heart. That's called an atrioesophageal fistula and can be deadly. The likelihood of that happening is estimated to be about 1 in 10,000. It's a very rare event, but it requires urgent surgery if it's figured out, and it can be deadly. So we do a lot of things to try to minimize the risk of injuring the esophagus. For one, anytime I'm ablating on the back wall of the heart, I use lower power on my ablation, and I don't stay in one place for more than about 15 to 20 seconds to prevent that thermal energy from potentially injuring the esophagus. In essence, we take a shallower divot, if you will, on the back wall of the heart, anywhere where we might be near the esophagus. I also put people on an antacid. I basically treat everybody like they have an ulcer for a month following an Afib ablation. And we send them home on some of the common names of these antacids are omeprazole or pantoprazole or lansoprazole. So you would go home on one of these for a month depending on what your insurance covers.